Good evening, everyone. Welcome. Thank you so much for joining us for this UMiami Health Talk, Uterine Fibroids, What Every Woman Should Know. A beautiful South Florida crisp evening for all of you to join us tonight. We have a lot of people interested in this topic. I'm health journalist Ileana Bravo, your moderator for this evening's program, which is presented by the University of Miami Health System Departments of Interventional Radiology and Gynecology. UHealth's interventional radiology and gynecology experts pioneer and advance the latest diagnostic, minimally invasive, and surgical procedures related to women's health specifically. UHealth offers access to the latest breakthroughs in research, treatments, and personalized care. As an academic-based program, we offer patients a multi-specialty care approach by a recognized team of experts. To learn more, please visit us at umiamihealth.org. Well, tonight, a special evening, we're going to hear from our interventional radiological expert, Dr. Prasoon Mohan, and gynecological expert, Dr. Jose Carunio, to answer your questions, and here are your topics. If you experience heavy or painful menstrual periods, bleeding between periods, or pain during or after sex, when is it time to seek treatment? Are there non-surgical options for treating fibroids in the uterus? And finally, when is surgery the best treatment for fibroids? Now, we hope you're going to join us in for this interactive question and answer session after our experts' presentations. Just enter them as you think of them. You're going to use your Q&A feature at the bottom of your Zoom screen. Take a moment on whatever device you're on to locate it so you know where to go. And our experts will address as many as they can as we tee them up for them and prepare them. So right now, it's my pleasure to introduce our first speaker, Dr. Prasoon Mohan, an internationally recognized board-certified interventional radiologist, an associate professor of clinical interventional radiology, and director of the Interventional Radiology residency program at the University of Miami Miller School of Medicine. Dr. Mohan has received numerous international and national awards and published dozens of scientific papers. His primary clinical and research focus is in uterine fibroid embolization. So let's give a nice welcome to Dr. Mohan. Take it away, Dr. Mohan. You can prepare your presentation, have it ready for us. And make sure to unmute so we can hear you.
Thank you, Ileana. Let me start sharing my slides. Good evening. My name is Prasoon Mohan. I'm an interventional radiologist at the University of Miami. Thank you all for taking time to join us in this webinar. So I will be talking about uterine fibroid embolization, which is a non-surgical treatment option for symptomatic fibroids. I would like to start this talk by asking two basic questions on uterine fibroids. This will kind of give me an idea about your level of understanding of the topic. So these are audience response questions. The first question is, fibroids are cancers. Is this statement true or false? Please answer.
All right, let's see how our audience has done on this topic, which is, something that not everyone is aware. So are fibroids cancerous, true or false? Let's see how our audience does before we ask our second survey question. The whole idea here is to learn, to be educated, to expand our horizons on these medical themes. So let's see how the answers are coming in, Dr. Mohan.
Okay, should I give it a few more seconds?
Yeah.
Okay, we have 96% of the audience responding that this statement is false. I'm happy. Thank you. Second question, what percent of women will have fibroids by the age of 40? So the responses are 10%, 20%, 40%, and 5%. So let's give a few seconds.
Apparently, doctor, both of them came up at the same time. So it seems that people already answered, as you can see on your screen. And what is your response to how well or how did they do?
Better than I expected. 65% got it correct. So very good. Okay, so let's start. Uterine fibroids are very common. So they are the most common non-cancerous growth in the uterus. They grow within the walls of the uterus. Up to 40% of women are affected by the age of 40. Most of the fibroids do not cause any symptoms. Only a small percentage of fibroids cause symptoms. And another important point to note is that African American women are at higher risk of developing fibroids. And fibroids also have a genetic component, which means that they tend to run in the families. So the picture on the right side, the graphic shows a fibroid within the uterine muscle wall. And the bottom image is an MRI scan, which shows the side view of the uterus. The uterus is outlined by this red line, and the fibroids are outlined by these yellow lines. So you can have multiple fibroids. Now, there are different types of fibroids based on where they are located. So intramural fibroids are within the muscle wall, so, as you can see here. Submucosal fibroids are fibroid those push into the inner wall of the uterus. This is a submucosal fibroid. And subserosal fibroids are the ones which push on the outer wall of the uterus. So this is a subserosal fibroid. And fibroids can be large and multiple. So if you look at the MRI image at the bottom, you can see that again, the uterus is outlined in red and multiple fibroids outlined in yellow. And as you can see, this is a huge uterus with multiple fibroids, which is filling the pelvis and extending into the abdomen. They can be diagnosed with ultrasound imaging. However, MRI imaging is the best modality because it gives us the location, position, and vascularity of the fibroid. Now, how do you know if you have fibroids? In other words, what are the symptoms of fibroids? So there are two main fibroid symptoms. One is the bleeding symptoms, and the other group of symptoms are called the bulk symptoms. The vast majority of the patients, the most common symptoms are bleeding symptoms. Among the bleeding symptoms, the most common symptom is heavy periods. So how do you know if your periods are heavy? If you have bleeding for more than 7 days, or if you have to change your pads every 2 hours or more frequently, or if you're passing clots the size of a quarter or bigger, that means you have heavy periods. That is the number one symptom of uterine fibroids. Less common bleeding symptoms include bleeding between periods and periods becoming closer together. Now, all these bleeding symptoms can eventually lead to anemia. And depending on the degree of anemia, the level of your hemoglobin, this can be a serious complication. And the most common symptoms of anemia is tiredness, dizziness, headache, and sleeplessness. Now, let's talk about the next group of symptoms, which are called the bulk symptoms. Bulk symptoms are from the size of the fibroids, fibroids and the uterus. The big uterus, the bulky uterus, presses on the other structures within the pelvis. And all these symptoms that I'm going to describe is because of the size of the uterus. So most common among the bulk symptoms are the pelvic pain or pressure. Many patients describe it as a chronic, low-grade ache or pain in the pelvis, or some people describe it as a pressure. Other people sometimes describe it as a heaviness in the pelvis. And rarely, people also complain of chronic low back pain. All of this could be bulk symptoms from large fibroids. Now, fibroids can also cause frequent urination. If you look at this image on the right, it's an MRI scan looking at the uterus from the side. It's a big uterus with multiple fibroids, and it's pressing on the bladder. The bladder is outlined in blue, and the uterus is outlined in red. As you can see, when that big uterus presses on your bladder, it reduces the volume of bladder. It reduces the bladder's capacity to expand, which will force you to urinate more frequently. Now, the next symptom is pain during or after sex. And again, this depends on the number, size, and the location of the fibroids. Fibroids can also make your lower abdomen distend or stick out, and it can also cause bloating. If the fibroids are pressing on your rectum, it can give you constipation. And finally, because the fibroids can distort the inner lining or the inner cavity of the uterus, they can cause infertility. Now, let's go to another audience response questions. The standard treatment for fibroids is the removal of the uterus. Let's see how you do on this question.
Yes, let's give them a moment to see how much knowledge we lay people have on these topics. And since what you're saying is that this is a common condition for women, it behooves us to know more. So the standard treatment for fibroids is the removal of the uterus. Is that a true or a false to our participants tonight listening?
Our audience has been doing great.
Yes, impressive.
Okay, false. 84% got it right. No, the standard treatment, the only treatment for fibroid is not removal of the uterus. So let's look at the treatment option for fibroid. So remember at the beginning, I said vast majority of the fibroids are asymptomatic. If your fibroids are asymptomatic, which means you don't have any complaints, you don't need any treatment. Okay, a lot of people out there have fibroids and they don't know they have fibroid. You don't need any treatment. Only reason for treating if they are symptomatic and if it is affecting your daily life. Okay, you have three treatment options: medical, surgical, and uterine fibroid embolization. The medical treatment, most common solution would be contraceptive pills, but they're not very effective. They can, in some people they can help, some people it doesn't. And the next is hormonal treatment. In hormonal treatment, these medicines try to oppose estrogen and progesterone. So they put you in a temporary menopause-like state. So they do shrink the fibroid, but once you stop the treatment, the fibroids can grow back. And these treatments also have significant side effects. So let's go to the next group of treatment, which is surgical. You have myomectomy, which is removal of the fibroid itself, and hysterectomy, which is removal of the whole uterus. And my dear friend, Dr. Karunya, is going to talk to you in detail about the surgical options. And the third minimally invasive non-surgical solution for fibroid, uterine fibroid embolization, or UFE for abbreviation. And I'm going to dedicate my talk to uterine fibroid embolization. So who is a candidate for uterine fibroid embolization? If you are a patient with symptomatic fibroids and you want to avoid surgery or want to preserve the uterus or want a faster recovery, which means minimal time away from work and family, or if you're a patient with high surgical risk from pre-existing diseases, then you are a candidate for uterine fibroid embolization. What are the advantages of UFE? It preserves your uterus and your fertility. It has a faster recovery. You should be able to get back to your normal daily activities within 3 days. You should be able to get back to work within about a week. It is associated with less major complications and there's no need for general anesthesia. And it can be done as an outpatient, on an outpatient basis, or with an overnight hospital stay. And finally, there are no scars. And what are the pre-procedural evaluation prior to a uterine fibroid embolization? Number one, we always try to get an MRI scan. Again, like I mentioned before, it shows us all the fibroids and also their vascularity. We get a pap smear and an endometrial biopsy. Both of them your gynecologist can do. Endometrial biopsy is similar to pap smear. It's an outpatient procedure. If you have an existing IUD, that needs to be removed. And finally, we do a urine analysis to look for any existing infection. The UFE procedure is done under conscious sedation. So we give you intravenous sedatives, which will put you in a twilight zone. You're not completely out, but at the same time comfortable. We use a radial or femoral access. the picture here shows a radial axis, and there are no cuts or scars, only a needle puncture. And this is the right side, the same patient's hand is shown, and the scar is barely visible. It's a needle puncture. Now, once we get the axis, we take a tiny catheter, which is a tiny plastic tube, and guide it through the arteries using X-rays into the blood vessel or artery that goes to the uterus. Now, once you're there, we embolize the small blood vessels that are going to the fibroids with beads. Beads are small balls, tiny particles which are smaller than grains of sand. And I have some graphics. So these images show initially getting access through the wrist, and this catheter is being guided into the uterine artery using X-rays. And the same way, the same procedure can be done through the groin also. You enter the groin and then get the catheter into the uterine artery. Now, once you're there, you release these beads. These are tiny balls, smaller than grains of sand. So what happens is these beads flow with the blood, and when they reach the smaller branches, they get stuck. They get stuck in those branches, and essentially what it does is it blocks the blood flow to the fibroid. And once the blood flow is cut off, they die and shrink over time. Now, here's some angiographic images, X-ray images from the actual procedure. So the first image that I'm going to show you is an angiogram before embolization. So you're injecting dye or contrast through the catheter to see the fibroid. So this large dark blob that you see, I'm injecting contrast, and it is making the fibroid visible. This dark blob that you see is a big fibroid. And after this, we do the embolization. And this image on the right side, the video that I'm going to show you now, is after the embolization. So again, in this image, you do see the big vessel, but you don't see that dark blob anymore, because all the small blood vessels, tiny vessels going to the fibroid, have been blocked, not the uterine artery itself. Now, what can you expect after the procedure? It's normal to have cramps after the procedure for the first 12 to 24 hours. This is because we cut off the blood going to the fibroid, and they're going to die. The dying fibroids send pain signals. And in a way, it's a sign that the treatment is working. We treat this pain proactively. We use a combination of pain medicines, steroids, and nerve block. At UMiami, we have a unique pain control regimen for the pain after the fibroid embolization. This is one of my research interests. We conducted a randomized controlled trial at UHealth, where we injected steroids into the uterine artery at the time of the procedure to see if it helped with the pain. It did help with the pain, so that's one technique that we use. And Dr. Karugna was one of my co-investigators on this trial. The second thing we do is a nerve block. There are nerves that carry pain signals from the uterus. So we can inject, under X-ray guidance, we can inject local anesthetic around these nerves, which will give the patient pain control for 8 to 10 hours. And finally, we give traditional pain medicines, Motrin-like painkillers and opioid analgesics. What's a recovery after UFI? The hospital stay, like I mentioned, it's less than 1 day. Most of the time, this is an outpatient procedure. You can expect to have mild cramps for about 4 days after the procedure. And these will be controlled by pain medicines. You can return to your normal activities within the house, shopping, driving, etc. within 2 to 3 days. You can return to work in about approximately 7 days. How successful is UFI? The embolization has been around for over 25 years. There's been multiple studies conducted in Europe, America, and elsewhere, which have shown that it is as effective as surgery in controlling the symptoms. Now, the images on the right side shows a uterus, the side view again, before embolization, and the right image shows 6 months after embolization. It is important to know that embolization treats all the fibroids in the uterus. Research shows that there is complete relief of symptoms in approximately 90% of the patients. In the remaining 10% of the patient, There is slight improvement or no change, but there's no worsening. Does UFE affect fertility? Now, fibroid embolization preserves the uterus and fertility. Again, this is another area of my research interest. We published the first systematic review, which is considered the highest level of research evidence on this topic. And we looked at all the prior studies on this topic, and we found that the pregnancy rates after UFE is the same as general population, provided that we adjust for the age. Now, there's also more research in this topics with people describing fertility preserving UFE techniques, so slightly different techniques for embolization in patients who want to preserve fertility. We use those techniques at University of Miami. And I also want to mention that myomectomy, which is a surgical removal of the fibroids itself, is another fertility preserving treatment option for fibroid. Risks of UFE. Now, about 2% of the patients has a risk of going into menopause, and this is mostly in patients over the age of 45 years. Second is fibroid slough. It can happen in 1 in 500 patients. If you have a fibroid that is sticking into the inner cavity of the uterus, sometimes they can slough off and small pieces will have to be passed. In very rare cases, they have to be removed with DNC. And finally, undetected cancer. Like any other organ, there is an extremely low chance of having an undetected cancer, 1 in 2,000. Recurrence. Any treatment where for fibroid, where you leave the uterus behind, there is a risk of recurrence. The recurrence is a penalty that we pay for preserving the uterus. At 5 years, there is about 30% risk of recurrence. And this is not because the treated fibroids are growing back, but because new fibroids are forming. But again, most of these new fibroids are not symptomatic and no treatment is necessary. UFE has a slightly lower recurrence than myomectomy. In conclusion, both surgery and UFE are effective treatment for fibroids. Hysterectomy or surgical removal of the uterus is a permanent solution. However, UFE has some advantages. It's minimally invasive. There are no scars. There is faster recovery. It preserves the uterus and the fertility. It can be done as on an outpatient basis, or you might need an overnight hospital stay. It is associated with less major complications. And finally, at UHealth, Interventional Radiology and Gynecology department work closely and provide comprehensive multidisciplinary care for fibroids. I have known and worked with Dr. Carino for many years, and I can guarantee that if you come to see us, we'll make sure you get the right treatment for your fibroids, whether it is surgery or embolization. Thank you.
Thank you. Thank you very much. Very informative, Dr. Mohan. And just so that you know, all of the people who are asking questions, they're getting answered offline also by our other expert tonight, Dr. Jose Carunio, who I'm about to introduce. So we really appreciate how interactive the audience is tonight. You're really participating and getting in. So let's go to Dr. Carunio now, who's an internationally recognized board-certified gynecologist with specialty training in advanced minimally invasive gynecologic surgery, laparoscopy, and robotic surgery. He's an associate professor of obstetrics, gynecology, and reproductive services and director of minimally invasive gynecologic surgery at UHealth. His clinical focus is managing fibroids, ovarian cysts, chronic pelvic pain, endometriosis, pelvic organ prolapse, abnormal uterine bleeding, hysteroscopy, infertility, and minimally invasive gynecologic surgery. Welcome, Dr. Carunio. It's time for you to share your presentation and make sure that you're unmuted so we can take advantage of all the information you have to share with us tonight.
Hi, Eliana. Thank you so much for this awesome presentation. I believe my slides are up. Can you see them?
Yes,
Great.
we can.
Perfect. So, Dr. Mohan, we have a very knowledgeable audience today, so which makes our work easier. But this is going to be a very informal conversation. We're here to answer all your questions that you might have regarding fibroids and give the solution to any problem that you will be having. So briefly, and I want to go back over a couple of important points that, in my opinion, is really important to get them clear out of this webinar is fibroids are non-cancerous tumors. Although you hear the word tumor, that doesn't mean cancer. They're 100% benign. There's other words that people use when referring to fibroids. They also call leiomyoma, which will be the medical term. Fibroma, it's also another word that people use, especially in Spanish, fibromas. And what they're made of is smooth muscle, which is the same muscle that makes the uterus. For some reason that we don't know exactly why, but we are actively investigating and doing research on the topic, the uterus, areas of the uterus starts growing, and that is what causes a fibroid. We do know there are some risk factors that might preclude patients to develop fibroids. And one is the race. African-American people have a higher incidence of fibroids. We do not know why this is the case, and we're actively doing research on the topic, but it's what we have seen. Also, it runs in families. So if your mother have fibroid, your sibling have fibroid, there is a chance that you will also have fibroids because they do run in families. Another risk factor is obesity and sedentary lifestyle, unhealthy eating habit that might develop fibroids. How do we classify those? We classify the fibroids depending on the location. So we name them intramural when are located in the middle of the muscle of the uterine wall. Then if they are right under the edge of the muscle, we call them subserosals. And then if they are inside the uterine cavity, we call them submucosal. And then there are some that are we call pedunculated, which is the fibroid grows kind of outside of the uterus and is attached to the uterus by a stalk. And why is this important? Because depending on the location is the symptoms that the patient is going to have. And as Dr. Mohan already mentioned, what are the symptoms? I'm not going to go over the symptoms again, but what I have to say is it really depends on the number, size, and location of the fibroids. It is easy to understand that the bigger the number of fibroids that you have, the worse the symptoms. Same thing with size. The larger the fibroids are, the more the pain and the bleeding that you will have. That is easy to understand. But what's important to understand is the location. Fibroids that are located inside the uterine cavity, regardless of their size, cause heavy bleeding, as opposed to the fibroids that are on the outside of the uterus, that those cause more pressure-like symptoms. So if they pressure on your bladder, you will have frequent urination, you will have pain during urination. If it pressure on your rectum, then you will have constipation or pain during when you do number 2. But if they are inside the cavity, you will have heavy bleeding. How do we know that patients have fibroid? Well, basically, we listen to the patients, to the history. So it's the patient that comes and say, well, I have heavy bleeding, pain, and then we'll do a physical examination. And here in this picture, you can see how when we do the pelvic exam, we can actually feel the fibroid, especially if they're on the larger side. And at times, we can press on the uterus, and if you put your hands on top of your belly, you can actually feel the fibroids when they're larger. And as Dr. Mohan already explained, if the fibroid put pressure on top of the bladder, then you will have urinary symptoms. And if the fibroid put pressure on the rectum, then you'll have GI symptoms that could be constipation, the most common one, but you can also have bleeding or pain during defecation. Then after we do the physical exam, what's the next thing we do? We do an ultrasound, as imaging. And the imaging studies basically is ultrasound and MRI. And I will also say here, the best imaging modality for the pelvis either for ovaries, you have an ovarian, you're suspecting ovarian cyst, or you have an abnormal bleeding, whether you have fibroids or not. The best imaging modality for the pelvic is always an ultrasound, and the transvaginal ultrasound that allows us to put the probe inside and take a really close look to the gynecologic organs. So we do the ultrasound, and the ultrasound will help us to diagnose the fibroid, or also we can differentiate from another entity. It's called adenomyosis, which is kind of similar to the fibroid, but instead of being localized in one area, it's a kind of growth of diffuse. The entire uterus get bigger in adenomyosis. But with an ultrasound, we can tell that difference. The other imaging modality is the MRI. What's good about the MRI is that it's going to tell us exactly the size, number, and location of the fibroid. And that's really important for me as a surgeon to plan my surgery. So as I said, what's important? The size, the number, and the location of the fibroid, because of the reason that I just said. Another important thing is the patient's age. It's not the same if you have fibroids in a young lady in the mid-20s, 30s, that had not have children yet and is planning to have a future fertility, as opposed to having fibroids at the older age, because one of the most important and worst symptoms that fibroid cause is heavy menstrual bleeding. Well, guess what? Once you hit menopause, bleeding stops. So if you have fibroids or you're close to menopause, sometimes just waiting a couple of years until you have menopause and then naturally cure your disease, because you're not going to bleed anymore. So it's important. The other thing is the severity of the symptoms. And this is also easy to understand. How quickly should you seek medical care? Well, it depends on how heavy the symptoms are. If you're having heavy bleeding and every month or excruciating pain, well, then I would recommend you to consult right away. But if you know you have fibroids and you know that the bleeding is heavier, but it's not that heavy, then you can plan your visit and then not necessarily need treatment right away. Another important issue is if you have other medical conditions like diabetes, high blood pressure, heart disease, because this is gonna also tell us what the treatment that we're going to give you, because we will treat you as an entire patient. We're not gonna focus only on the fibroids, we'll treat the entire conditions that you have. Cancer is another important point, because there are medications, for example, for this breast cancer, people take medications called tamoxifen that helps to reduce the recurrence of breast cancer, but might increase the chance of having uterine cancer. So all those drugs are important. What are the treatment options? And I like the very first one. The very first one is expectant management. Do nothing. That is always an option, especially if you don't have symptoms. If they diagnose the fibroids because they have an ultrasound because some other reason and they find fibroids, you have no symptoms, there is nothing that we need to do other than monitoring those fibroids, making sure they're not growing and we don't know about it. Then we have non-surgical options like birth control pills that we can actually use to treat the symptoms. There is other drugs like tranexamic acid. There is a device, it's called the Mirena IUD. All those medications we use to treat the symptom, to treat the heavy bleeding. There is these GnRH analogs that what they do, they induce a medical menopause. So we give you medication to simulate a menopause. And again, the menopause will stop the bleeding, and that's how we treat you. Then there is the uterine fibroid embolization and radiofrequency ablation that are other non-surgical options. But the surgical options, which is what I do, there are two basically big categories. One is what we call uterine sparing, which we keep the uterus, and it's called the myomectomy. We do not remove the uterus. There is chance for you to continue to have future fertility, but there is also a definitive treatment, which is the solution of the problem, which is a hysterectomy, that in many cases, it's probably the best option for the patient. As the different surgical options that we have the minimally invasive access, which will be laparoscopic or robotic, or we have the classic open, like a C-section cut kind of surgery. And I'm going to go over those different options in a second. The one that we do the most and we try to do whenever possible is with the minimally invasive access, which is laparoscopic or robotic. That's those keyhole incisions that allows me to put instruments inside the body and work inside the body from the outside and detaching those fibers through those little keyhole incisions that will allow you to go home the same day and have an expedited recovery, like 1 or 2 weeks at the most. Remember I said the location is important of the fiber? Is because if you have these fibers that grow inside the cavity, that those are the ones that cause the heavy bleeding, there is an option that I can go through the vagina and put a camera inside the uterus, which is called a hysteroscopy, and remove those fibers from through the vagina with no cuts at the belly or anything like that. We do the procedure today, tomorrow, you're fine like nothing happened. And sometimes those fibers that grow inside the cavity, they create this stalk that we said, and the fiber actually comes out through the vagina. It's delivered through the vagina. That causes pain and heavy bleeding. But the good news is this is another of the fibers that we can treat vaginally without doing any cut in your belly, and the recovery is immediate. When we talk about classic surgery, because not everybody is a good candidate for a minimally invasive access, we could use classic C-section type of cut that is transverse, but when the fibers are too big, sometimes we need to go up and down. That is extremely rare, but it happens when the fibers are really, really big. That's why we would like to intervene before the fibers become big, because the bigger the fiber, the bigger the incisions that we need to make. So what will happen the day of surgery? If we decide the surgery is the best option for you, first we need to do a pap smear and an endometrial biopsy that we do it in the office, that, in a pre-op visit where we answer all your questions. Then you will be admitted to the hospital. We do an IV. Then we take you to the operating room, right? At that point, you're under anesthesia. You're not feeling any of this. We give you antibiotics through the IV, making sure you don't get an infection. And then, depending on the procedure that we do, most of the time you go home the same day, and you might stay 1 or 2 nights of stay if we have to do those big classic surgeries. And then we'll have a 2 weeks post-op appointment for a post-op check. To conclude, a couple of frequent questions. The first and most important one: will fibers become cancer? And the answer is no, without hesitation. They do not become cancer. There is one type of fiber that is cancerous. It's called the leiomyosarcoma. But that is not a fiber that becomes cancer. That's a cancer that starts from the get-go as a cancer. Happens more often postmenopausal patients who have other cancers, who have received radiation on the pelvis, or taking these drugs, as I said, tamoxifen, and they develop a sarcoma. It's not a benign that becomes cancer, as I said. It's a cancer from the get-go. Very rare, usually in the elderly population, 1 in 2,000 is the frequency. How common are fibers? Well, we just learned today that they're very common. The causes, unfortunately, we don't know, but we are doing research trying to find the reason. Oh, my mother was diagnosed with fibro. Am I at risk of having them? Yes. Well, I just said they run in families. So if your mother had one, there is a chance that you might also have it. Will fibro become cancer? I'm going to say the same question a million times, and the answer is no. And will they go away without intervention? Also, unfortunately not. Do I need to have them removed? Same. There are different options for treatment. Another one is, can they be removed with laser surgery? And I want to take this opportunity to classify. Laser surgery is used for other types of procedures. The myomectomy is done with laparoscopic or robotic surgery, not laser. If a patient has fibroid, will she be able to get pregnant? Yes, but some fibroids actually cause infertility, especially when they are bigger than 4 or 5 centimeters and they are in the middle of the uterus, like inside the cavity or in the transmural. Those cause infertility. And how long will you be out of work after surgery for fibroid? It depends on what type of procedure you have. If it's open, it's been a little bit longer, 3-4 weeks. If it's with a minimally invasive access, 1-2 weeks, you'll be back to work. And here my poll question, Ileana. So if we determine that the best treatment for your fibroids is surgery, which one would you prefer? A laparoscopic approach, a robotic approach, or you prefer to have an open, classic surgery approach? And the 3 options are equally valid. It's a choice. You can choose whichever you think is best for you. Based on what I just explained, I'm curious to see what the audience will choose. What do you think, Ileana? What would you choose if you were to have a fibroid removed?
I would go with 21st century medicine technology. Either give me the minimally invasive laparoscopic or robotic, which sometimes is very similar, but I don't think any woman in this audience tonight wants the open approach C-section if they can avoid it.
Let's see. I'm curious. Let's see what the response are.
And we have so many questions tonight. So there you go. You see, the women are.
You're right. You're right. Very good. And actually, it's interesting because that is pretty much the what we do. We do mostly laparoscopic and robotic, and a very few open cases, which is also a valid option. Don't get me wrong. So a couple of take-home points. Again, fibroids are the most common benign tumors of the female genital tract. Most are asymptomatic. You have no symptoms, you need no treatment. Remember, expectant management was my first option in the list. If you do have symptoms, there are many different options. One advice, though, this is my friendly advice: seek you medical care early and in a center that has the multidisciplinary options, meaning that the center where you're seeking care have all the options available, so you are the one choosing the one that's best for you, and not limit yourself to go to a place that have only limited options for you to choose from. And with that, I conclude. Those are my phone numbers. If you like to schedule an appointment with me, sometimes the phone it's hard to get. Feel free to send me an email. That's my personal email. It goes through my cell phone, and I'll reply to you as soon as possible. I'll have my secretary reach back to you to schedule an appointment.
That's very
Thank you so
generous
much.
of you, Dr. Carunio. Thank you so much. And if you didn't have a chance to see all that information, folks, don't worry. At the end, we're going to have that screen up with the contact information for both of our medical experts tonight. So Dr. Mohan, you can come back and join us so that we can start going with our questions. We've received dozens, and you've been able to answer some of them offline, and we'll do our best with live now. So let's begin with the first question, that this was a pre-submitted one, and that is, can fibroids shrink through diet or exercise? And let me expand on that even further. I've heard you say that just by virtue of the fact that we're women and the hormones are going to drive these fibroids, we're already at risk. Secondly, there could be familial history and a genetic component to this. So what can we do to prevent, to help ourselves?
Well, again, as I said, we don't know the etiologies, right? We don't know what causes the fibroids. However, we do know that healthy lifestyle and exercise prevent it from happening, as we know that obesity is one of the risk factors. So if you're healthy, you lose weight, and you live a healthy lifestyle, it's gonna help you to decrease the chances of having fibroid, among many other, health benefits that you will get. There is also an association with vitamin D. Interesting enough, decrease of vitamin D has been associated with increased prevalence of fibroids.
Very interesting. So again, we do have some control. Lifestyle matters. All right, here's our second question. What fibroid treatment options exist for women who want to become pregnant?
Maybe I can answer this. So the two options, you have to pick a urine preserving option, urine preserving treatment option. So the two options that you have are fibroid embolization, UFE, or myomectomy. Typically, when we have these kind of patients, I discuss the case with Dr. Carugno, and we make a decision based on the type of fibroid, the age of the patient, and how easy is it to either take out by myomectomy or by embolization. So these cases, it is important that we have a multidisciplinary team.
Okay. A lot of this same question was asked by people in the chat box, and that is, why do fibroids appear to come back even after surgical removal?
Very interesting question. It's some of the fibroids are microscopic, so you cannot see them. So what happens most of the time is that the surgeons will remove as many as they can, or will remove the ones that they see. But there are some that are microscopic that at the time of the surgery they haven't developed yet. But remember, the patient who has fibroid has the increased risk of developing them. So sometimes what happens is the tiny little ones are not removed. So, and those grow over time. And as people think, oh, they came back. It's not that they came back, it's that they were not removed at the first place. Which is really important to have this multidisciplinary approach, because we order an MRI. Remember, the MRI is more accurate to look up for the small ones. And when we discuss this with the radiologists, we can determine the exact size, number, and location of fibroids, so we know the numbers that we need to remove before we actually go to the OR. And it's not that we go to the OR and see how many we find. No, we know how many the patients have, and we go after those.
Yeah, thank God for scans and ultrasound that allow us to see
Exactly. Eliana, let me ask a question, because I received many questions while Dr. Mohan was talking about adenomyosis. So many people ask about adenomyosis and fibroids. So what are what is the role of uterine fibroid embolization in adenomyosis?
Sure, thank you for the question. So adenomyosis is slightly different from fibroid. This is where the inner lining of your uterus is actually present within the muscle of the uterus. So it can cause you a lot of pain during periods and bleeding also. So now, recently, over the last 5-10 years, there's been more and more evidence coming that uterine fibroid embolization can treat adenomyosis. The success rate is not as high as fibroids, but it is over 75% people have long-term symptom relief from adenomyosis after embolization. This is a condition, as Tony can probably elaborate, with not a lot of good solutions.
Yes, and unfortunately, surgical management is difficult. It's not the same as you can remove fibroid. It's really hard to remove adenomyosis. It's a very bloody and morbid procedures. We prefer to treat medically those patients. So, but it's important to understand that although both happen in the uterus and both cause heavy, painful periods, they're two different entities with totally two different treatments.
So it's either adenomyosis or fibroids that can cause the heavy bleeding and the pain. Any other conditions that a woman might have and think, oh, I have fibroids? Anything else that causes the heavy bleeding?
Oh, yes, heavy bleeding is caused by many conditions. Hormonal imbalance causes heavy bleeding without the need to have an organic cause. There are functional causes of heavy bleeding. problem with coagulation also, that also runs in family. Those people have heavy bleeding. So that's why it's important. Heavy bleeding is never normal. When the period lasts more than 7 days, when there is pain during menses, pain during intercourse, pain is never normal. And it's a reason to seek medical care.
Yeah. And we can peek into the Q&A box while we're chatting here if you'd like to as well. So we can look and see if there are any questions here that you want to grab while I also queue up some other ones. It occurred to me that you said African American women are also at higher risk. Is it cultural? Is it also Hispanic? Is it, and why?
Let Tony answer this.
Then no, the Hispanic has the biggest is the African American population, followed by Hispanic, followed by Caucasians. That's just, demographics. Again, we don't know what causes them, but we are actually at the University of Miami doing serious research trying to find an answer for that very interesting question.
Okay. Dr. Mohan, anything jump out at you in the Q&A? Dr. Karun, you just glance over because I think
Sure.
we have 40 questions in there. Might as well take a look while we're considering our other options. Also, can you live?
Yeah.
Go
Yeah.
ahead.
No, what was the question, Lena?
I was going to say, can you live safely with fibroids other than the total discomfort I can? In other words, it's not a life-threatening, or I mean, it could be an infertility-causing condition. So there you go.
I actually wanted to go there and wanted to spend a few minutes talking about the role of fibroids on infertility and pregnancy. Infertility could be one of the symptoms of fibroids. Same way as heavy bleeding, infertility that could be one of the symptoms. Usually, when the fibroids are larger than 4 centimeters and the patient is not able to conceive, we recommend removal of that fibroid. What happens if the patient gets pregnant and has fibroid? Nothing happens. Fibroids during pregnancy behave the following way: 1/3 growth becomes bigger, 1/3 stay the same, and 1/3 actually shrink during pregnancy. So what's important is, again, the size, number, and location of the fibroids during the pregnancy. What the fibroids could cause is, because especially if they're in the lower part of the uterus and the baby stays on top, then you will not be able to have a vaginal delivery because the fibroid will prevent the baby from coming down through the canal, and you'll have to have a cesarean section. But nothing bad is going to happen to your baby. There is no risk. It's a little bit of a higher risk pregnancy. If you do have fibroid, you must disclose it with your obstetrician, but it's nothing bad is going to happen as long as you have adequate prenatal care.
Dr. Mohan, anything that you saw that's interesting? If not, I'll ask you something else.
There was a question, how do you diagnose adenomyosis? Again, the best way is MRI. They can distinguish between adenomyosis and fibroids. And before uterine fibroid embolization, we do get an MRI, and that can pick up adenomyosis. And UFI is a good treatment option.
Mm-hmm. Another thing that I saw coming over is, can birth control pills, taking birth control pills may create fibroids? And I think it's the opposite, right? It's one of the treatments.
Yeah, yes, it's one of the treatment of the symptoms, not of the fibroid. With the birth control pill, we'll treat the bleeding. We prevent the fibroid from causing bleeding, but the fibroid stays the same. The birth control pill doesn't make it grow, doesn't make it shrink. The fibroid stays the same. The birth control pill, what it will do is decrease the symptoms, so decrease the heavy bleeding.
So what I'd love for you both to do now is to do a take-home message for our wonderful audience tonight, who's been so patient and participating. And I know they're going to want to contact both of you for their conditions. But I'll start with Dr. Mohan. If you could give us a message of 21st century medicine. And I say that not lightly, because it's important for people to know that those kinds of conditions are so treatable today and more minimally invasive than ever. The future is here, and rather than fear, awareness is really what is important here. Dr. Mohan, go ahead.
Sure. And number one thing I want to stress is this is an extremely common problem. A lot of people have these symptoms and they just push it to the side and get on with their life. There are good solutions. There are good minimally invasive solutions. There are good surgical solutions, like Dr. Karugna, excellent laparoscopic and robotic surgeon. I can do UFI. There are multiple simple, quick solutions to this problem. You don't have to live with this. If you have these symptoms, the worst thing you can do is like ignore it, and you end up having anemia and then complications from anemia, needing blood transfusion, iron transfusion, etc. You don't need to get to any of those points. There are simple solutions, and please seek help.
And Dr. Carunio, again, an inspirational message. This is not your grandmother's fibroids anymore. This is.
I agree with you 100%. And that's the beauty of coming to a university center where we are academic, we are on the top of research. Any research that gets produced about any medical condition comes out from university centers. So that's why the benefit of coming to us is because we have that capacity. We have the infrastructure to create research, to create a multidisciplinary approach. We are in South Florida. Español también se habla aquí. Eso también es importante. Needless to say, my accent gives it out. Yo hablo perfecto español. Soy venezolano. So we are here to help. And
Thank you. Thank you, Dr. Carunio. That's important that, it's academic medicine. That's where they're going. So take a look at the scan on your screen, the QR code. For appointments with Dr. Mohan, call 305-243-2067. This is a moment now while I'm talking for you to take a picture of your screen if you're watching the Zoom call. And for Dr. Carunio, it's 305-243-4960. Our experts. Thank you so much for the generosity of your time tonight. To our interactive audience for participating and being there. Doctors, if you'd like to say goodnight to them, I'll leave people with more information to visit.
For carving time out of your evening. Thank you for joining this webinar.
Thank you.
Thank you so much. I'll see you in the office.
Please visit UMiamiHealth.org for more information. Here are your numbers again for Dr. Mohan, 305-243-2067, and Dr. Mohan, 305-243-4960. I think I inverted those, but either way, they should be on your screen. It should be showing you what you need to see. But in any case, thank you so much for participating. Please do the survey at the end to tell us what else you'd like to see in the future in other webinars. In the meantime, good night, everyone. Stay safe out there. Have a good one.
Bye-bye.